Hello, welcome to the One Health Lens podcast, where we have conversations about global health, public health, and the road to universal health coverage. I'm your host, Dr. Diana Wangari Gitao.
And I am Dr. Simon Moshara Kigondu.
Last time we had a conversation around universal health coverage, the 4 bills which are spearheading Kenya's road to universal health coverage, right? We had Social Health Insurance Fund as one of them, or Social Health Insurance Act, right? And as under Social Health Insurance Act, we had three funds, right? We had Primary Healthcare Fund, Emergency Chronic Critical Illness Fund, and then the Social Health Insurance Fund, right? And I think this was the big discussion point because this Social Health Insurance Fund was contributory, whereby we had 2.75% being deducted from paychecks and what have you, right? And a big question that came up was, it's fine, we're going to repeal NHIF, the National Hospital Insurance Fund. Okay. And we're putting in Social Health Authority, right? And the question there became that, okay, we have contributions coming in. What are the benefits, right? And essentially the conversation today is the document is not yet out, but there has been some engagement with different stakeholders around the benefits and tariffs package, right? So we have in studio a guest who's going to give us a little bit of insight around the benefits package. Kigondu here will be poking holes because, as always, he's part of these meetings, which he doesn't invite me, but it's fine. We're hoping in season 2 some of these things change. But let's start with the guest. Maybe he can introduce himself. Hi, Dennis.
Hi, Dad. So nice to be back.
Yes.
Long time.
A long time, too long.
So, Dennis, a health strategy consultant, and a Kenyan. I have to
important
for this session. Yes, very important.
Yeah.
And passionate about healthcare in Kenya.
Absolutely.
Yes.
Thank you. I mean, one of the reasons you're here is because, one, you do sit on the Managed Care Committee at Kenya Medical Association, right?
Yes, I do.
So you're in a position whereby you are able to see some of these documents before the public sees them, and you and the committee, amongst other stakeholders, give insights, right? Feedback before the final documentation comes in. And also because you're not in government, we expect then there'll be a little bit of representation.
Proper, hopefully. Yes.
Hopefully, right?
Yeah.
I mean, I've looked at this document, right? Mm-hmm. And I always come in from a point of, I'm a layman, right? And I mean, there's a lot of words in there that I'm like, okay, fine. As long as I get services I really don't care about, right? But to me, it looks like a very comprehensive document. Mm-hmm. I mean, I'm seeing inpatient, outpatient, I'm seeing mental health being covered, and it's covering the spectrum of prevention, promotion, curative, palliative, rehabilitative, as the case might be. So to me, it looks as if for the contributions we'll make, right?
Yeah.
We might be on the right track, right?
Okay. Right track.
Track, yes. Right? But also I appreciate that it's not also quite clear what I am essentially getting if I am being deducted XY, right? Whether I'm a formal worker or informal, right? But you've had an opportunity to sit in these meetings. What exactly is being proposed as the benefit if I'm going to pay, right? If I expect healthcare services in this country, what benefits will I get?
Okay. Yeah. So as a reminder, this is their first proposal, at least the first one we've seen, and the hope is the insights we give them, they'll actually use to shape it to something better. So we've come from far. We've come from a place where there was nothing to begin with. Yeah. We've seen the history of the National Hospital Insurance Fund,
yes,
the National Health Insurance Fund, and, moving from purely covering only hospital inpatients and then only civil servants, and then allowing people who are formally employed but not civil servants, and then expanding. So we've come a long way. This is probably the last leg to UHC, and I'm sure we've all
At
heard
least
about
service provision.
yes,
Yes.
we've all heard about the 2.75%, and you recall the discussion we had last time. It's all going to 3 different funds. So we need to establish 3 different funds. One to take care of primary healthcare, which is the I'd call it outpatient or low level, not necessarily low level, but first point of contact healthcare. Then you have the SHIF, which is a social health fund, social health insurance, which for all intents and purposes, it's literally your NHIF today. And then you have the emergency critical chronic illnesses, or chronic and critical illnesses fund. So for the first time, we'll start covering accidents and emergencies, critical illnesses, your ICUs, your HDUs, that will now be covered. So we are starting from a good place.
Yes.
If you allow me, then I can just go highlight a few of the packages.
Yep.
As presented, this is a proposal. I don't expect a lot will change. Of course, there might be changes before then. But one thing we decided to hold them account to, and I hope they do this, is that this will be made public.
Yes.
Because a big problem has been today, whoever pays for NHIF, at least most people I know, do not know what their cover entails.
Exactly. You don't know what benefits. You have to pay.
Yes, you don't even know what you have to pay. This discussion happens behind the scene. And so you can't even participate in cost control yourself and say, no, I don't need to utilize this if this is the limit. So you can't. You are told the push is, no, go to hospital if you are ill. Don't worry about the
which ironically is different from the private sector, where usually when you enroll a scheme, you get education session, member education session, where you're told you'll have maximum of 100 for optical, dental, whatever it is, maximum of this for maternity, and these are the facilities you can go to, so that you're aware that this is what my cover essentially covers, or these are the
to plan.
right?
I mean, there are some things that you would wish to plan for, right?
Yeah, absolutely.
And if you have that opportunity to do that, then you can plan.
Absolutely, absolutely.
So what they have done is they've listed the basic services. So outpatient as a start, you understand the capitation model.
Yes.
For the viewers maybe who might not understand.
So essentially, they are using a capitation model for outpatient.
Yes.
And in this case, what it means is that a certain amount will be given to a provider to provide these services, right? So amount X, let's say it's 1,000, whatever amount it is, right? I've seen an amount here, I'll not mention it, but let's assume it's 1,000. So if I run Hospital Diana, I know that for every patient I see, I'll be given 1,000. And then at that 1,000, for every belly button.
Yes, every patient who registers with you.
Every patient who registers with me.
So the implication means at the start, as you're registering for your SHA, you pick the hospital which you will be going to first. And that hospital automatically will receive a certain amount of money per head, per belly button. So if you have 5 people in your household and the 5 people pick the facility, those 5 people would get, if it's 1,000 shillings, 1,000 times 5,000 is paid to that facility upfront.
Okay, so then that means number one, we will all select a facility that we would want to go.
Yes.
right?
Yes.
And that facility will already get, say, this 1,000 for, say, the 100 people who have registered with hospital. Let's go with
Yes.
Hospital Diana.
Yes.
Hospital Diana has 100 people registered. Since capitation means that for every person registered with Hospital Diana, I get 1,000, so I will automatically get 100,000.
Yes.
And that means for that 100,000, these people, whether they come in or not, I receive it.
Yes.
But also, I must find a way to utilize this 100,000 to give them service. So if they come for consultation, they come for drugs, if they come for lab tests, whatever it is, I must utilize it within that budget.
Within that budget, yes.
I have questions, but continue.
Yes. So essentially what that does, it transfers what they call risk from the insurer to the provider.
Okay.
The hope is the provider will not be tempted to misuse, right?
Okay.
That's the hope, that then, because you've received the money upfront and this is the only money you have to work with,
Yes.
then you will not go and order tests that are unnecessary, or give drugs that are unnecessary.
Okay.
So that's the intention. Whether that happens is a different discussion. What they will do, they will, instead of paying we're using 1,000 shillings, instead of paying the 1,000 shillings upfront, they propose to pay 900 shillings upfront. So 90% of the figure upfront.
Yeah.
And they will spread this 900 shillings, divide it into quarters. I mean, they'll figure it out.
Yeah.
But the 100 shillings will be retained and will be used for two things. What they call portability, meaning you could get ill when you've gone to your rural home and your facility is not nearby. So then they activate that 10%. Or you could be on a trip somewhere, right? And you are ill, and the nearest facility to you is not your primary facility. And then there is what they are calling pay for performance.
An important element.
When what we have as ears on the ground is an upcoming bill that is going to be called the Quality of Care Bill, or something to that effect.
Yeah.
That will then define standards of quality that then will be used to reimburse this 10%. So what I mean is, if I have 100 patients, as you said, they will have a metric to say this hospital has managed this 100 patients well compared to another facility with a different 100 patients. And so this hospital will probably not get the 10% and the other hospital will get the 10%.
Okay, I mean, it's fair. And actually, and just as a by the way, so I've been attending these health economics sessions by Health Economics Research Unit at KEMRI, KEMRI Wellcome Trust. Thank you, guys. I'm learning a lot. So I know one of the case studies we had to undergo was this performance indicators, right? And essentially what they were saying was that to ensure that a facility meets certain criteria for quality, because as you said, if I give you 1,000 upfront, you can go in whatever direction, right? You need to find a way to hold back so that you're incentivizing in one way and also ensuring that there's quality, right? So maybe even holding back is not a bad thing. It's not a bad thing.
What you'll have to play around with is what are these metrics?
Indicators.
That's what we need to know before you start holding providers to those standards. Then you need to tell them this is what I expect. Is it complication rates for a condition? Is it referrals, right? Because you could get a provider who say refers most of his patients to the next facility, but he's already received the money. But why are they referring? Is it an escapist mechanism?
Yes.
Or is it that they are in an area where, by virtue of the people around them, people are more ill, and thus they have more referrals?
Yes.
So there has to be something. There has to be a way of investigating and saying this is that.
Okay, fair enough, because I know there's that mention of it will include referrals of contracted services and
Yes.
whatnot. Okay, fine. So outpatient package essentially is there's a list of services
Yes.
that essentially you'd be entitled to as the Kenyan citizen or someone residing in Kenya, right? And that list of services will be given to the provider and
Yes.
they'll know, and it will be on a per capitation model.
Exactly. And maybe to add one last thing, you can only utilize this initial package at level 1, 2, or 3 facility.
Now,
Now I've introduced the so if we go back to our notes, in Kenya we have 6 levels of hospitals. Level 1 is not really a hospital; it's what we would call the community health unit. Essentially, I would say what is under a health care worker, a healthcare community health worker. 1,000 households
Yes.
would be called a community health unit.
Okay.
Then above that we have health centers, which are your level 2 facilities.
Okay.
Dispensaries become your level 3.
Yes.
Your sub-county hospitals are your level 4.
Okay.
Your level 5 are the county referral hospitals.
Okay.
So 47 of them ideally.
Yeah.
And then your level 6 are, so I say
The referral.
the county referrals are level 5.
Yes.
Yes. And then your level 6 are the 3 national hospitals. So
Yeah, the Kenyatta Nationals, Moi. Yeah. Okay.
Yes.
Okay.
So your outpatient care can only be sought as a start from a level 2 or 3 facility. So your health center or your dispensary.
So essentially, the assumption there will be at the point of registration, they will limit registrations to those facilities.
Exactly.
Okay. And so you should know that, in fact, it won't be up to the citizen. It's because then I'm assuming that you will register only to one level 2, 3 facility for
Yes.
outpatient.
Yes.
And so if you have, say, the minor ailments which can be sorted out, it's not specialized care that's required. You'll
That's where you
present
start.
yourself, you'll get treated, and that's fine, right?
Yes.
Inpatient, I require to be admitted before we even go further. Inpatient.
So inpatient would either be at a level 3, right? Or any of the other levels. So you will get a referral that's then written from this level 2 or 3 facility, and then you will go and get admitted with that.
Okay.
Yeah.
Okay. So then essentially between outpatient and inpatient, you're more or less covered.
Yeah, you are. I would guess so. So your inpatient has gone back to what NHIF used to do a while back. Previously, they used to have a bed rebate. That's what they would call it.
Yes.
So an amount they were giving per
Per day.
day. They've adjusted that amount
Yeah.
and spread it with based on the level.
Yeah.
So a level 2, level 3 actually, because admission will be level 3,
Yes.
would get less, than level 6 would get the highest, but it's a per diem rate.
Model.
So
Okay.
then the facility has to figure out how to sort you out inpatient medical, and I need to be precise, inpatient medical, meaning there's no surgery happening within that amount.
Okay. So, and it's interesting you've said we've gone back, because most Kenyans, if they were to talk about NHIF and what they would miss, forget the controversy and whatnot, right? What people used to recognize was, I have Linda Mama, there were these packages, civil servants, super cover, all this, right? And so it's not so much about even inpatient, outpatient. People would consider those because of certain cases, right? If I'm pregnant, I knew I'd be covered. If I had a certain condition, I knew I'd be covered, right? I would be covered not just in public, but also in private. Those elements, do they still remain, right? Let's take the example of, and Kigondu, trying to bring Kigondu in. I'm pregnant today, right? I first need to go for my antenatal care visits, then I'll need to deliver, there's follow-up that will need to be done. Kigondu, from what you've seen, being an OBGYN, is that covered?
So I think, thank you very much. These discussions are important, and I think they keep evolving. And a lot of times, I think people mix so many things, and sometimes you get the baby being thrown away with the bathwater. So you have the concept of healthcare financing in terms of towards UHC, so that you do not get catastrophic expenditure is good, and this is a process in which we are working towards. It's not a destination, so it's a journey. And Okaka and I participated in
the meetings,
Ministry of Health, those meetings, which we don't invite you. And I'm usually very clear in what objectives do we want to achieve, and trying also to demystify some of the issues that that are pushed as political statements vis-a-vis what is on the ground. And my approach is to be practical, to actually use what was there before, the figures, the activity, and what was there after, and that makes comparison very easy. And I'll go straight to civil service scheme, because we've been there, and you realize that there was opposition to the way they just brought in the social health schemes and abolished the civil service scheme, with the argument that civil servants are being subsidized by others. But let's use an example, and I'll go straight to a simple example of delivery. Let's use cesarean section as an example. In the civil service scheme, depending on your level, let's say, and civil service has levels, job groups, so to speak. There are various benefits for various groups. And what was the reason? The reason is because the way the civil service is structured is that the higher you are in the civil service, the higher the pay, of course, and the higher the sort of payout to benefits. And I'll use, let's, for example sake, let's use job group R. And deputy director of medical services as an example. They would previously, we say the civil service scheme was crafted by the late Mwai Kibaki government, and in that one they removed the medical cover, and assuming this civil servant who is in job group R was getting 5,000 shillings for medical cover. So this 5,000 shillings was actually removed from the pay slip and taken to NHIF as the contribution of this particular person towards the pooling in NHIF. Secondly, there is the mandatory, or what are called statutory, deduction of 1,700, which would mean that this civil servant who is in job group R and is a deputy director of medical services providing medical services would be paying 6,700 shillings per month. And at the end of the year would have contributed 72,000 to 80,000 shillings for his medical cover. Yeah. And what were the benefits? At that time, the benefits was that you could choose any hospital, and you would sort of get covered. Yeah. And this means that this person would not go into financial distress doing out of pocket. What is the situation now? And maybe Okaka has not touched it. And what they presented to us was that there are 3 levels. And the 3 levels are red, which is the facility that will be given a contract where you will not charge, and you will take what has been prescribed in this benefits package. And these benefit packages, and at least from what was presented, cesarean section was 34,500. And therefore, this hospital that has taken 34,000 package, so someone would go in and get a cesarean section, and the social health authority would pay 34,500. There was a second level where they say that they would give a contract, it was Orange, I think. They would give a contract where you would pay 80%. SHA would pay 80% of that, but you would be allowed to co-charge to 30%, 30% more than what is there as copy. So that facility that is seeing this, that 4,000, so not the actual charge. It's not the cost, so to speak, it's a tariff. So this second hospital, what would be the calculation? It would be 34,000 plus 130% of that, which would be about maybe 40, let's say. So they would receive 34 from Social Health Authority and 70.
34, 80% of 34.
Oh yeah, actually it's not 34,000. It will be 80% of 34,000. To reduce that guy to 80%. Plus now you would charge 130%, 1.3 of 34,000. Let's say 40,000. So you'd get maybe 60. Let's say, when you add the two. So that's the second tier. The third tier, they say that you would get 20% of what is prescribed there as the benefit. So that would be 20% of 34,000, which would be, how much would that be? A fifth. So it's 34 divided by 5, 6,000, maybe 7,000. Yeah. And then you can charge. Is there a limit to that?
No,
there's no limit you can charge. So, being that civil servant, maybe I want to go to a high end, so to speak, private hospital. Then for my wife, who is delivering, they would pay 7,000, and then I pay the rest. My problem with that is this particular civil servant now, assuming their gross pay is a bit high, and maybe they are paying 15 to 18,000 a month. That would come to about 15,000 in 12 is 30 times 6. They have actually paid for their medical cover 180,000 to 200,000. To have a cesarean section, they would only be paid for 7,000 by the Social Health Authority. That is now the picture that they were giving us. So our concern in terms of feedback of that is that is you're having equity, which they keep preaching. You have equity on receiving the money. Percent. But you do not have equity on the benefits. So that's a problem.
Let me even, because that's why some of this conversation are interesting, because I almost want to, take notes, make calculations, but let's take it back, right? Essentially, when we're talking about UHC, it's quality service when you need it without you undergoing financial distress. And why it was important was because we don't want this inequities, right? If you're in Nairobi and you're in a corporate, you can access care versus someone who's somewhere out deep in wherever county, right? And there's the idea there is always that if you require some essential medical services, you can access them wherever you are, right? Okay. For this to happen, there are certain things that need to be there. It's not a building in itself. It's multiple healthcare workers, governance. There's a financing element. And a big part of this is always the financing element, right? And financing, when you go into it, there are multiple elements into financing. The component we're talking about here, and I'm even pulling some of these notes in this class, by the way, strategic purchasing, right? And the strategic purchasing is usually the element around which which interventions are you going to purchase? You select the providers, you source the resources, you decide on payment methods. So by the time you're coming up with a benefits package, right? It's not just about we're going to give these benefits because you've contributed or because these are the different funds. It's also an element of provider being paid, right? And these are the tariffs, right? Which Kigondu was saying, right? So then essentially what Kigondu is bringing out is we might focus a lot on the benefits, which again are quite comprehensive. I am impressed by how well listed they are, right? But for us to deliver on these services, what I'm hearing is there's a concern that comes from, first, there's not enough clarity, but there's also a concern around how the providers, the hospitals, the facilities that are giving the services are going to be contracted, right? Because we're all selecting a facility, right? We're selecting a facility, whether it's level 2, 3, 4, whatever it is, you'll go to a facility. And so for these facilities, there are different classes, right? That's what I'm hearing. There's class 1, 2, and 3. There's green, orange, yellow, and red, right? And so for these facilities, in your contract, you're going to have different provisions, right? So if you're in the red, you are more or less guaranteed to get 100% paid, right? So
It's a green.
Oh, it's a green,
yes,
right?
Yes, yeah.
Right. The green, of course. The green, if you're in the green, you are you've opted as a facility to take the green contract, and all this I'm just using as placeholders. There's proper terminology for it and probably wording that will come along with it. But so if you're a green facility, essentially what it means, your contract with SHA as Hospital Okaka now will be that SHA will give you money for the services 100%. So if I've delivered at Hospital O, right? In that case, if cesarean is going to be covered 34,000, I essentially will get 34,000 as Hospital A, right? That's green facility. That's the contract for green. Then if you're in orange, by the way, it looks yellow to me. I don't know if it's orange, but to me it looks yellow. But okay.
But the 34 means, for the green means, so yes, 34, and you're not allowed to charge the patient more. Okay.
Yes. So essentially what you see is what you get.
Yes.
That's it, right?
Walk in, walk out.
Walk in, walk out to you. Perfect. So, and there's no clarity around who's going to go for this facility, this contract green. There's no clarity. Okay. Then the orange contract, right? These are facility hospital, Kigondu, Hospital K, right? They've opted for orange contract. What this means, if what they are to be paid for every CS that they perform in their facility is 34,000, they will be paid by SHA 80% of 34,000, right? Yes. So Hospital K, knowing that, if I'm getting 80% of 34,000, yet my costs are higher, Hospital K has the option of adding a little bit more to the cost, right? I mean, to the price or the fees, right? So then in this case, Hospital K, if I go to Hospital K, they can charge me up to 30% more or...
Yes, up to 30% more than the
34,000. Yes. So then I will potentially pay, not the 34 now, I will pay more. So I will... chances are I'll have to pay something either from my other insurance, with the assumption is I have private insurance, or cash, right? Cash. Then there's Hospital Red, which is Hospital D, which essentially I have opted for red contract, which means of that 34,000, I will only be paid by SHA 20%, right? But as Hospital D, I have the option of charging whatever I want. Yes. So then I will figure out my internal workings and then decide if you're coming to have a CS in my facility, I can charge you $1 million if I want. Okay, maybe it's excessive.
And I hope you're really seeing the problem with this. So we're in a market where you have, for all intents and purposes, a monopoly buyer who's setting prices, because now they're giving you a price, a contract. Take this or leave it. Yes. And that for part of that contract, you cannot charge more. It's your business, but you can't charge more. I'm the one who's paying. I'm
forced to take what's on the table.
You can't pay more. You can't charge them more. Or, if you want to pay more, I am restricting what you can pay based on what I have decided again. So a restrictive trade practice from a monopolistic buyer who's fixing prices, right? And who's restricting you and telling you, even if you want to charge, you'll only charge as a percentage of what I say.
I mean,
Keeping in mind
yeah.
The amounts that are
Extracted. That's the word
extracted
from you.
these amounts, without going into details on, say, for example, 34K, these amounts are not
Cost.
they're not costed. They are based on what they think they can afford. So they are not the true cost of their care. And if you want to understand that, look at so let's pick something like cancer screening. So there's a package that then has cancer screening for the 3 cancers you normally can screen for from a population standpoint: cervical, breast, and
Prostate?
cervical, prostate, colorectal. Yes.
Yeah, okay.
Okay. Breast, I will tell you the problem with that. So cervical cancer, prostate cancer, and colorectal. So for prostate cancer, the guidelines say once you hit 40, right? I think it's 40.
40 years.
Yeah, you should start population-based screening.
Yes.
Because of financial constraints, our what SHA would pay for is going to start at 55. Right?
Yeah.
So again, what I'm saying is they are not fully following science or fully following cost. So they've made decisions based on costing, which is okay. Okay?
Yeah.
We would understand that. But
It feels like there's
Right.
an attempt to force the market in a certain direction, right?
True.
And maybe this is a conversation for another day in terms of economic principles and whatnot. But because it's obviously there's a budget they're working with, there's a healthcare budget, because I mean, Shine itself has to tax fund primary healthcare fund, right? Has to tax fund the emergency critical chronic, right? So essentially, the emergencies, if you have a chronic illness, is not so much about your contribution. Although I saw something here around, anyway, but that's a different conversation. So we're focusing right now on SHIF, right? And if you're focusing on that, essentially what it sounds like, there's a force towards, yes, you'll get benefits, but you'll get benefits within the facilities that we want you to go because we can cost control them, right? Because potentially all these facilities have taken contract green, right?
Yes.
Because they already know that they're being reimbursed everything, right? So if I see a patient for my cough and cold, flu, whatever it is, I know I'll get everything prepaid in this capitation model, right? So there's a force towards certain facilities. Then additionally, there's, as you're saying, they're controlling for this risk through the provider of the services. Because then it becomes me as the facility, I have to figure out how give all the services with this amount. But also, if now you're introducing all these elements of additional tests, who can do it? They'll only, behind the scenes, it sounds like, reading between the lines, it sounds like a medical officer, because then I'm assuming, I mean, the rate for Kigondu versus the rate for Diana is different, right? And Nemo versus is very different, right? So there's a certain push, not explicitly mentioned, in as much as this is an explicit type of agreement. They don't state it, but there's a push towards that. And all that is being driven so much by the budget and the pressure they are under, right?
Or a push to then say we should seek these services, say, at a public facility, right? And expect private facilities to change their costs to fit what is competitive to a public facility, without considering the HR costs that a public facility does not have to incur, because as a public facility, I do not have to pay for my staff,
and whatnot.
and potentially even my licenses, or even if they do, government never really charges government, as they say. So the number of licenses you can get by walking into any facility versus any other private facility, any public facility, I wonder whether you will see licenses plastered on one wall from KMPDC, Music Corporate Society of Kenya.
You don't. It's a government facility.
License to operate. All these things. So we can't have them at the same level.
I mean, I agree with you. July 1st, let's do it, but let's do it with some sensibility and say we're doing it. July 1st, SHA is on, deductions will be made, but these are the expectations, so that then we're not all expecting to walk into any facility. Because I tell you, the number of people who have told me I expect to walk into any facility and get my services are so many that I've gotten to a point where I've stopped even explaining, because
and they don't realize it's not any facility. It's only level 2 or 3 facilities,
exactly.
Right?
I mean, Kigondu, last words, because we could go on.
Yeah, so I think there are nuances to the Act and the regulations that are also sort of overlooked, such as those who cannot pay will be paid for. Yet that's a serious nuance. You will pay 300 shillings. That's a serious nuance. Means testing will be done. That's another serious nuance. And this, I think, was part of the feedback that we gave the Senate Committee on what are they calling it, legislative agenda or something, the one headed by what's his name, the Tana River MP. I've just forgotten, but we have had data from the registration of IDs. We have had birth certificate registration. You see, I mean, why don't we use this data? We have data issues for children. But at the end of the day, I think let's stick to basics. Universal health coverage is to try to ensure that everyone does not undergo catastrophic health expenditure. Yeah.
I mean, that's why we're here, right? To continue this education, right? Because it's not going to be a straightforward journey. It's not. And I feel like we'll learn a lot along the way. And maybe some of the requests we have will not be had, others will be had. But that's why we're here on the One Health Lens podcast. Thank you for joining us.